Good evening, everyone. We are MedGenome, leaders in genetic testing in India. And today we are doing a webinar series in association with Prime Diagnostics and Imaging Chandigarh. And this is an interesting concept. So we are combining sonology and genetics. So this is a sonogenetics webinar series, and this is the first of a three-part series. And the topic for today's webinar is Midline, Supratentorial fetal brain, normal sonoanatomy, anomalies, and genetics. So we have three speakers for the evening. And so without further delay, I will just move to our first speaker for the evening. So our first speaker for the evening is Dr. Amitam Kaur. She is a fetal medicine, fetal imaging specialist and consultant at Prime Imaging. And she has worked with Mediscan Chennai, Dr. Suresh. She has multiple awards to her credit, including top of her batch of PMD, MS Gynecology in Amritsar, top of stood first among 8 medical colleges in the university for 3 years, and several distinctions in her MBBS academic career. And she also has several publications in national and international journals. And she's also the member of multiple societies, including the Society for Fetal Medicine, OGSI, ISUOG, and other societies. And so without any further delay, I will now hand over to Dr. Amitam and request her to start us off. Over to you, Dr.
All right. Hi, good evening, everybody. So I'll just share my screen.
So audience, if you have any questions or comments, please use the Q&A window for your questions. We'll address them at the end of the session. Thank you.
All right. Am I audible? Because
Yes,
I got a message that my net was unstable. So I hope I'm audible.
You're loud and clear, and your presentation is also clearly visible.
Perfect. All right. So I'll just start.
Sure.
All right. So on a whole, first, thank you. A big thank you to MedGenome. We know that they're doing an amazing job in the field of prenatal genetics. And we've started this small little series known as the Sonogenetics series. We'll be taking in neurology first. So we'll be dealing with just the fetal brain. And I hope by the end of it, we all can do an advanced neurosonogram with great ease, as we end this series. We're going to start with part 1 today. That is neurosonogenics, and today we are just going to deal with the anterior complex of the brain, anterior midline complex. Now, this is a supratentorial midline fetal brain that I'll be talking about today. I'll be taking you through just the normals today, and then we can further move on. Ladban's ma'am will be taking in the abnormal, and Dr. Meenakshi will be taking in the genetics of the abnormal CC and CSP. All right, to introduce, we all know that most organs, during the fetal period, they only increase in size, be it the stomach, bladder, kidneys. What they're doing is they're increasing in size. But the brain, however, it undergoes major developmental changes until almost the last weeks of intrauterine life. It starts as early as 3rd week of gestation. It is a continuing process. So whenever you look at the fetal brain, you'll be seeing something new. Every week you scan, you'll be seeing something new because anatomical changes, they are seen throughout different periods of gestation. Now, that having said, we can't really see the brain every week. We can't call the patient back and scan every week for every anatomical feature that is appearing in the brain. So what we do is we can bookmark the fetal brain. If I was to do 2 scans to wring blood from stone, that is to maximize information from the fetal brain, I'll be doing one at 11 to 13 weeks. That is my NT scan. I get a lot of information about the developing fetal brain at that time. And second, I'll be scanning at 18 to 20 weeks. That's a normal TFA scan or the target scan. All right, so ISWOG, we all agree with ISWOG. That's the Society of Obs and Gynae, International Society of Obs and Gynae, and they have said that the ideal stage to look at the developing brain is between 18 to 22 weeks. The axial views, which are the standard views, we'll be talking about that later. They are a gateway to assess most of the midline anomalies. And whenever we have a strong suspicion of something going wrong in the axial view, we always move to the other views, especially to the sagittal view. All right, so these are the planes of imaging. The rule of ultrasound is that you have to see everything in two planes, be it the fetal head, be it the kidneys, be it the stomach, bladder. You have to see it in two right angle planes. So these are the standard images, standard planes of imaging. So can you see my cursor? My cursor is moving, right?
Yes,
All right.
moving.
Perfect, perfect. All right. So that's the axial view right there. That's the horizontal view. If I cut the brain like that, I will get the axial view. This is the coronal view. So if I'm cutting the brain like this, I get a coronal view or a frontal view. And if I cut the brain like this, I get the sagittal or the parasagittal views. All right. So we all know that axial view is very easy to get. We all do it in our BPD planes or our transventricular planes where we measure the ventricles. It is, our hands shake when we go to the coronal views or we go to the sagittal views. But this, I would like to show you the power of 3D here. So a single sweep, all these images have been generated by the machine. I have not done anything here. What I did was I focused on the transventricular plane. I took one sweep of 3D, and from my X, Y, and Z axis, I got all these three planes, and I could see structures that I could not see on the axial view. All right. So now we move on to the axial planes, the three standard planes for imaging the fetal brain as a beginner, or when we don't go to the sagittal often, we just start with the three axial planes, and if we suspect something wrong, then we move on to the sagittal planes. So transventricular, transthalamic, transcerebellar. We all know this. These are all basics. So the rule of three here, the rule of three in every plane we have to apply. We see the midline falx, we see the CSP, and we see the lateral ventricles. That is why this is known as the transventricular plane. The second plane, these are the thalami here. So that's the transthalamic plane. And this is the cerebellum here. So that's the transcerebellar plane. Now, what is common here, if you see, is the midline falx and the CSP. These two things are common here, and these constitute to what I'm going to talk about today, that is the anterior and the posterior midline complex. Now, what is the anterior or the posterior midline complex? It is a group of supratentorial anatomical structures which are reproducible in every simple transventricular view. So what we are going to do is we are going to focus on just the transventricular view today, and we're going to talk about the anterior complex more and just a word about the posterior complex. All right. So what I said was that these are a group of supratentorial anatomical structures. Let's see what is the tentorium. Now, if you see here, this line right here, this echogenic structure is the tentorium. It divides the brain into the posterior fossa, which is behind, and the anterior structures. So anything above the tentorium, which is here, is a supratentorial structure, and anything below is the infratentorial structure. Okay. So now we are going to move on to the topic of the day, that is the anterior midline complex. What does it comprise of? We have 5 things to look at in the anterior part of the brain. So if you see, this is your transventricular view. And if we focus just on this part, not only the CSP, we all know the CSP, we all know the brain box, but we have to focus on other things around the CSP to make sure that things are normal in the fetal brain. So what do we see here? We see the interhemispheric fissure, number 1. We see the Callosa Sulcus, this is number 2. We see the genome of the Corpus Callosum here. That's the first part of the Corpus Callosum. I'll be talking about CC more in detail as we move on. So that's the genome. And we see number 4, the CSP. It's not always a box. Please remember, it can be a triangle as well. And laterally, they are hugged or flanked by the anterior horns of the lateral ventricles. So this whole thing comprises of what we call as anterior midline complex. So again, revision, that's the interhemispheric fissure or the midline falx. That's the Callosa Sulcus. This is the genome of the Corpus Callosum. That's the CSP and anterior horns. Okay, now I'll be taking 2 or 3 slides on every structure so that we understand them in detail. Now, first, the interhemispheric fissure or the midline flux. What it does is it bisects the brain into two halves, as we can see here. We see on ultrasound as an echogenic line which is running craniocaudally in the axial section. It is only and only interrupted by the cavum, septum, pellucidum, and nothing else till the tentorium. So the only thing that we see interrupting the interhemispheric fissure is the Csp. In sagittal view, we see a fan-shaped structure, an echogenic structure right in the midline, which is the interhemispheric fissure of the midline flux. Okay. So again, some beautiful images here. We see a TUI where we can take multiple slices of the brain. We see the interhemispheric fissure, the midline flux right throughout here. And this is a 3D render of the interhemispheric fissure. Here we see the lateral ventricles and we can see the parieto-occipital sulcus as well. Second, the first we've discussed midline flux. Now we're going to take you through the Callosa Sulcus. Now it is a reflective pia covering over the outer surface of the corpus callosum. This is all bookish. Basically, where do we see it? It's just above the corpus callosum, and the pericallosal artery it runs here. So this T-shaped structure, please remember the T sign for Callosa Sulcus. So here, if we see this is the T of the Callosa Sulcus. Again, different images. Here we see a T. This is hardly 18 or 19 weeks where we can see the T clearly. The T in coronal section. We can see this line here, which is the Callosa Sulcus, and the T again in coronal TVS, which is very, very clear in this image. All right, now for the next few minutes, I really want you to focus, and we obviously can focus when we see this man in picture. There are no doubts about it. We all know who he is. And basically, if he enters the world of fetal neurosonogram, or if he was to enter the world of fetal neurosonogram, he would be the Csp. Why? Because the Csp is the hero of the brain. So the unsung hero. Why the unsung hero and who's the heroine? Well, Csp is the hero. The heroine is the corpus callosum. And we all know that the hero will take a bullet for the heroine. So whenever something goes wrong with the heroine, the hero will be there, take a bullet, take the shot, and be dead in no time. So basically, the Csp guides us through all callosal anomalies or all CC abnormalities, including CC dysgenesis, hypogenesis, different types of malformations. This is a huge, huge list of malformations where the unsung hero dies. And we call the Csp as the black brain box, which is very, very important. All right, so what is the Csp? It basically develops as septa pellucida. So if you see here, this is a 12-week scan. You can see early signs of Csp here. These are the two septa. This is septa pellucida. And here, these are two paired membranes. If you can see, those are the two septae, and the box in between there's one cavity or cave, which is the Csp. The posterior extension of the Csp is known as the cavum vercae. I'll be talking about that as well. The development of the Csp starts at 12 weeks. It gets completed by 17 to 18 weeks. So the ideal time to look at the brain, to look at the Csp is always after 18 weeks. And as I've already told you, the heroine is closely related anatomically and embryologically to the Csp, or the hero of the show. So multiplanar imaging, here we can see this huge cave, that's the CC. This is the Csp. Again, the Csp in the coronal section and the axial section. Again, TUI sagittal imaging, right in the midline here, this dot here and this dot here signifies the Csp. Again, a 3D render of the Csp, that's the anterior horn, that's the midline flux going straight through, that's the Csp or the cave in between. Right, again, an axial image. Now we all know when we start from above, we can see the Csp, the anterior horns, the ventricles, we move down to the thalamus. And do you see something here? Now that's the box that we've been talking about, the black brain box. Now this is neither black, this is neither a box. So here something has gone wrong. This is not the Csp. Now what is this? We are dealing with the phonics here. What is the fornix? The CSP is posteriorly limited by the columns of the fornix. So the box is interrupted by the midline forks right here. This is not the CSP. It is not related to the heroine. And this is a potential pitfall. We should be very, very careful of not labeling the fornix as the CSP when we scan. Okay, so here's a video showing you. I'm going posteriorly here, and you see the box has disappeared. The box appeared, I go posterior, and the box disappears. So that's the CSP, and this is not the CSP, that's the fornix. Right, now, what is the cavum vergae? It is a posterior extension of the CSP. This is normal throughout all gestations, and we usually see this in the third trimester. It's just a posterior extension of the CSP, and this is a normal variant. Okay, CSP ratio. Now we come across things like a thin CSP or a thick CSP or a dysmorphic CSP or an abnormal CSP. Well, there has to be some objectification, or there has to be some ratio or some value which defines the CSP so that we can objectify the fetal brain more. What we can do is we can take this ratio. This was introduced by Professor Rabichau, and he said that you take the width of the middle of the CSP, not the largest part, because some fetuses have a triangular CSP, as we've seen, and we take the length from echogenic to echogenic line. And what we get here is the ratio from these two measurements. So you can find these nomograms on net. Just type in CSP ratio and you'll get this article by Professor Rabichau, and you can take down the nomograms, you can paste it in your the scan room, and this would be of help. This length to width ratio is of help. Okay. What we need to remember is whenever you're scanning, the length should be 1.5 times the width. That's the easiest way to remember the CSP ratio. So you have to fit two small little boxes to make a rectangle. So 1.5 times the width, and we are good to go. Okay, now talking about the heroine, that's the corpus callosum. It starts to form between 12 to 18 weeks, and it is almost completed by 22 weeks. The bundle of fibers, it is basically a bundle of fibers that connect the left and the right brain. It is the largest white matter commissure connecting the two cerebral hemispheres. It roofs the CSP, that is, it forms a cap over the CSP. And this is interesting. It consists of around 200 million to 250 million axonal projections. So such a small structure contains so many axonal projections, and they hold a lot of importance. Dr. Meenakshi will be telling us the importance of genetics and the corpus callosum later on. So if you see here, that's the corpus callosum. This is the cave beneath. That's the CC. CC here, the genu. We'll be talking about the parts of the CC as we move on. And that's the corpus callosum in the midline. Okay, so moving on to the parts. So we have the rostrum, genu, body, and the splenium. These are the 4 parts of the corpus callosum in prenatal life, and we can always measure all these parts whenever we find the corpus callosum to be dysgenetic, or whenever we find that it's unequal along its entire length or width. Okay. So in the axial section, the only part of the corpus callosum that is visible is the genu. We can obviously locate the genu here in the axial section. It is seen in its entirety only in the mid-sagittal plane. We'll be talking about mid-sagittal planes as well. What is important here is, as you know, we don't really measure CCs in every patient. What do is we just see a mid-sag section, and we see if it's overlying the tectal plate. This structure here is the tectal plate. If it overlies, or if it's overhanging the plate, we are in the right plane. And it's obviously roofed by the pericallosal artery, which is the branch of the anterior cerebral artery. Okay, that's how we image the corpus callosum. That's the mid-sagittal plane, the CC here, the CSP. I'm sorry. That's the thalamus, the brainstem, and here is the vermis. All right. So how do we image the mid-sagittal brain? Well, we have the 3 sign, the famous 3 sign here. Whenever you're getting this 3, you are in the midline. I think I'll just take a minute and have some water. All right. All right. So here, whenever I'm in the mid-sagittal plane, I'm seeing the 3 here. That's the thalamus, that's the brainstem going below. Whenever I get this 3, I'm in the mid-sagittal, right bang on sagittal plane, where I can see the parks very clearly and I can see the corpus callosum very clearly. Now also there's another sign, that's the kidney bean sign. So whenever I see this kidney bean, that's the vermis, I'm in the midline plane. So either the corpus callosum, the 3, or the kidney bean vermis with the fastigium here, I'm in the right plane. Okay, measurements, we all know we can measure from outer to outer, inner to inner, and we can measure each and every structure as we move on gestation to make sure that we are imaging a proper corpus callosum or a normal corpus callosum for that gestation. These are the nomograms, all available in books and on the net, and we can paste them in our, we have a book where we have all these nomograms of the corpus callosum, of the inner outer ratios, 5th centiles, 95th centiles, so that we have it in hand whenever we get a patient of a certain abnormality. Okay, now the last part here are the anterior horns of the lateral ventricles. We've discussed the interhemispheric fissure or the midline parks. We've taken care of the T sign, that is the Callosa Sulcus. We've taken care of the corpus callosum in great detail. The CSP, always the hero of every brain. And now we move on to the lateral ventricles, the anterior horns in particular. So these are lucent spaces. They are not filled by choroid, second trimester onwards. Adjacent to the CSP, what they do is they hug the CSP like both hands. And these are normal variants. You can find an anterior horn which is a little thick or triangular flanking. What is more important is that they have to be concave like that. Okay, so anterior horns again in coronal imaging, lucid, without the choroid, and this is the CSP, that's the T sign, that's the Callosa Sulcus, and this is the genu of the corpus callosum. Again, a video showing you here, I have the choroid, and once I lose the choroid, I'm in my plane. Here I've got the choroid, so I'm in the lateral ventricle area, I'm in the body of the lateral ventricle. Again, anterior horns here, that's the CSP. Is the midline parts, the CSP, and as I move behind, I'm getting the choroid plexus. TUI imaging, again, T sign, I'm repeating everything so that we are all set to register. That's the Fox that's just seen above the head, just little caudal. That's the Fox, that's the anterior horn right there. That's the CSP in picture, laterally flanked by the anterior horns. That's the Callosa Sulcus. The genu starts here. Here we see the genu, and here we see the lateral ventricles. We've entered the transcaudate or the transthalamic plane here. Okay, measurements, we obviously can take measurements. There are nomograms available for everything nowadays. So from the midline Fox, we take this measurement here till the anterior horn, and from the anterior horn to the anterior horn, echogenic to echogenic line, we can place them in our nomograms and see if we are dealing with a normal anterior horn of the lateral ventricle or not. Okay, a word about the posterior complex. What it constitutes is the splenium of the corpus callosum here, the Callosa Sulcus again, because it's going like a ring in the sagittal view, the interhemispheric fissure, the parieto-occipital fissure, and laterally the medial walls of the lateral ventricle. So what is the take-home message here? We all know that we have to follow the rule of 3 for all axial planes. The 90-degree rule to image fetal brain, that is, whenever we see the spine, turn your probe 90 degrees and you'll get the axial head. If the baby is looking up, if you see the orbits, you turn your probe to 90 degrees and you'll get a sagittal section. If the baby is looking down, you turn your probe to 90 degrees and you'll get a coronal section. We need to understand that we have to focus now on the anterior complex and not just the CSP. Nevertheless, the importance of the black brain box remains. The Csp ratio is very important, and it's a new thing, and that's how we objectify the cavum septum pellucidum nowadays, and it is a potential marker for partial agenesis of corpus callosum. the T sign for callosal sulcus, the 3 sign for the midline brain, the kidney bean sign for the midline brain, and how we can maximize information from a single 3D sweep. Right. Thank you.
Thank you very much, Dr. Amitam, for that insightful talk. So if there are no questions, we'll just move on to our next speaker for the evening. Maybe we'll come back and have the questions. So our next speaker for the evening is Dr. Ladman Kaur, and she is a senior consultant radiologist at Chandigarh with Prime Imaging. She was a senior lecturer with the Government Medical College in Chandigarh, and she's a faculty at ICOG courses for ultrasound examination of endometriosis. She's also a faculty at the GE Midway, conducting training programs and workshops for them. She has pioneered various procedures like transvaginal ultrasound in the region, peripheral Doppler, post-trimester, and 3D, 4D ultrasound. And she has multiple achievements, including best paper at the 8th ISOG International Symposium in 2012. And she's presented papers at the World Congress on Ultrasound and Obstetrics and Gynecology in Vienna and Singapore and Berlin. She has multiple publications in various national and international journals and authored a book called Atlas of the First Trimester Ultrasound. And she's also done presentations at various national and international fetal medicine updates. And her key interests are in fetal diagnosis and intervention. Over to you, Dr. Ladman.
Thank you, Joseph, for a very, very kind introduction. And at the outset, I'd like to thank MedGenome and all the delegates, who have joined in today for a webinar on sonogenetics. It's a series, and we begin with the first is the neurology. And in that particular series, we have taken up a very small area. And I'm telling you, this is such a crucial area that each one of us has to image. And not only image, we need to document it. So that, whenever we are going to go back and see our images, we have it on hand. And so that any issue, arises in the 3rd trimester, at least your documentation has to be complete. And especially when you're talking about Csp, which is seen as early as 16 weeks onward, and of course, more confidently at 18 weeks of gestation. So with that, I would be sharing my screen, and here I am going to speak on the abnormal Csp and the Corpus Callosum. And we have heard Dr. Nathan speak about the normal, and just to reiterate and to say that we have the CSPs in the prenatal period, it's a fluid which is seen between the 2 laminae, right? And in the postnatal period, these 2 laminae fuse and are called as septum pellucidum. There is a variant in the shape. You have in about 73%, you will be looking at a rectangular shape of the cavum septum pellucidum. I'll be referring it as CSP. So is everything going on fine, Mr. Joseph? My slides and my cursor, please.
Yes, madam, they're clearly visible and you're nice and clear, audible.
And it's about triangular in shape in about 25% of individuals. So CSP is linked to the development of the prosencephalon. So if you have a problem in the cleavage of the 2 cerebral hemispheres, we will have holoprosencephaly. If there is a problem in the separation of the 2 ventricles, we would not only have holoprosencephaly, but also we would be looking at septo-optic dysplasias or agenesis of septum pellucidum. If there are problems in the development of corpus callosum, we would be seeing ACC, could be partial, could be complete. If there is an issue about optic chiasma, our eyes, we would be also looking at SOD, which is septo-optic dysplasias, and even we need to think of Aicardi syndrome. And do not forget about the cortex, because they have a link with a schizencephaly and polymicrogyria. So whenever we have problems with CSP or CC, we need to go, and these are the things to be watched for. This is how you need to fit in your protocol, not only looking at CC or CSP. If you're looking any problem, if there is any problem with CSP, mind it, this is the list you need to go in for and look at each and every area meticulously. So add CSP in your protocol. That's the message. Layout of my talk, I'll be talking about holocrosencephaly, I'll be talking about ACC, I'll show you all cases of ACC complete as well as partial. We will be talking about septal agenesis. Also, we talk about septo-optic dysplasia, how to differentiate, what is the key area to differentiate the two. And then we will be talking about the abnormal shape of CSP, thin, short, wide, etc. We would be also touching at the end about the midline developmental cysts. So the first is absence of septum pellucidum, what is called as looking at holoprosencephaly. So holoprosencephaly, the stages of the holoprosencephaly, we do understand there's a problem in the cleavage of the prosencephalonic structures. So it depends how severe is the lack of the cleavage. So you'll have more severe, more evident, easily detectable at 12 weeks is what is called as a lobar. And we don't need to see a lobar in the second trimester, right? It's a first trimester diagnosis. Semilobar, little more challenging, diagnosed even in the first trimester, and of course in the second trimester, and extremely challenging, tricky situation when you're looking at lobar holoprosencephaly. Let me show you. Alobar holoprosencephaly, well, you do not see the CSP. It's very clear. You don't see the anterior part of the forebrain, right? So Fox is absent. The frontal horns are not there. And of course, the lateral ventricles are fused and form a large monoventricle. It's a large cystic area with a small little fused thalamus seen at the base of the brain. And it's categorically seen at first trimester. And there is a very good sign in the first trimester. You do not see a butterfly sign. You would see the communicating choroid plexus. The butterfly is gone. You see a monoventricle and you see a communication with a choroid plexus. And that's the diagnosis of alobar in the first trimester. And of course, looking at alobar in the second 16 and 18 weeks is also seen. Coming to semilobar, let me share you a case. You do see the fusion of the thalami and you see a monoventricle anteriorly. But if you ever try to map the circle of Willis with a color Doppler or power Doppler, what is going to be deficient is the anterior circulation. You will not see the anterior communicating branches. You would not see the ACA, the anterior cerebral artery. You would not see that because it's a part of the development of the prosencephalon, right? And you do see, of course, facial abnormalities. You do see hypothyroidism, closely spaced orbits. You may see absent nose, as you see in this fetus. You may have more facial abnormalities. That's the proboscis. There's arynia. There's a large proboscis seen arising from the forehead. More challenging. Let me tell you, this is at 16 weeks I'm seeing. This is what is called as lobar holoprosencephaly. There is absent CSP. I've taken still images from this particular video showing you no CSP. So concentrate on that box. It's seen in the and interrupting the anterior 1/3 of the intrahemispheric fissure. Try to concentrate in every scan dedicatedly at the transventricular plane. Your transventricular plane has to be perfect. It has to be horizontal. You cannot have oblique planes and try to visualize that particular structure. Wait for the baby. Be patient. It'll come. And that is absent. And you do see a communication of the frontal horns, and you do see the communication, or you see abnormal shape of the choroid plexus. You don't see the choroid plexus like this, right? So this is at 16 weeks showing you lobar holoprosencephaly, challenging, but it can be less challenging when you oblige yourself to see the midline. So more challenging. That is when you see variants. Midline hemispheric variant is a part or is a type of holoprosencephaly where you do see the communication, you do see absence of CSP, that's the communication, and it is subtle. But if you see CC is present, corpus callosum is present but is dysgenetic, predominantly in the rostrum and the genu area, because that's again the anterior component of the corpus callosum. So it is a dysgenetic corpus callosum. And of course, this baby also had a large midline cleft and also had shown us polydactyly involving both hands and the feet. So they all forms of holoprosencephaly predominantly show facial abnormalities in the form of median cleft, cataracts, arynia, single nostril, what we call a sebocephaly, ethmocephaly when you have an absent nose, and a proboscis and cyclopia. So I've just tried to group it into all. They all are part of what you call as trisomy 13 or a Fetal syndrome. Coming to the next entity, agenesis of corpus callosum. Now, in agenesis of corpus callosum, incidence varies from 1 in 200 to 1 in 5,000. It has one direct sign and many indirect signs in the planes which you are looking at your normal brain. That's the axial sections, right? The 3 axial sections, the 3 golden planes of looking at the brain can give you enough hint that you're looking at ACC, right? It is thus that we supplement it by the direct sign that CC is not absent looking at the sagittal and the cornal planes. So suspicion is raised on an axial plane and completed by other planes, sagittal and cornal. The best plane of imaging is the transventricular plane. If you're looking at ACC, the first sign is absent of CSP. As you see here, there's no CSP. And of course, that's the normal CSP to show you. So that CSP needs to be seen at the level of the lateral ventricles here. And if you look at the CSP is, remember, it's in the anterior 1/3. And if you're looking at a structure which is in the center of the brain and a little lower than the level of the lateral ventricles, this is not CSP. That is a third ventricle, which is commonly dilated and is seen in ACC. So remember, do not confuse it with a third ventricle. And also, the third ventricle is flanked on either sides by the thalami. So then the next is the dilated intrahemispheric fissure. Once you don't see the corpus callosum, you don't see the axons, we don't see the bundle, right, which is, through which multiple millions of axons are traveling, you will see there will be dilated intrahemispheric fissure. They are pulled apart, right? And what gets into the 2 cerebral hemisphere is the fluid. And the fluid gets into the 2 cerebral hemispheres, makes you show the falx and the medial walls of the 2 cerebral hemispheres, producing a 3-line sign, which is a powerful marker of ACC. You may also see 5 lines, and the 5 lines are contributed by the margins of the dilated third ventricle, which is displaced cephalad. So you may have 3 lines, multiple lines, and that is another marker. In uninterrupted intrahemispheric fissure is a marker. It has to interrupt. It needs to be interrupted. So you need to see the CSP carefully and make sure that the intrahemispheric fissure is interrupted, so that you may not have dilatation of ventricles every time. In 18 weeks, you may have normal lateral ventricles. So your CSP gives you a hint. I'll show you. Then you may have divergent frontal horns. So if you have divergent frontal horns, that's another marker. In normal, you have convergent frontal horns. They hug the CSP, right? And the frontal horns are divergent because of the dilated intrahemispheric fissure, because of the multiple lines, they diverge. So the frontal horns is another sign. Then colpocephaly. Colpocephaly is an advanced feature seen predominantly in the later part of the 2nd trimester and the 3rd trimester, where you see this dilatation, preferential dilatation of the atria and the occipital horn, and they are pinched frontal horns, producing a typical teardrop appearance and what is called as colpocephaly. And of course, another marker, if the red line here is bigger or longer than the yellow line, then also you start suspecting ACC. And third, you may have normal sized lateral ventricles. That I told you, you may not have advanced colpocephaly as seen in the later part of the second trimester. So loss of the sigma curve, that's the normal sigma curve of the lateral ventricle, right? The S-shaped curve. Whereas when you have ACC, you will have loss of this particular sigma curve. The medial wall of the lateral ventricle becomes flat and parallel to the intrahemispheric fissure. So there is loss of the sigma curve, there is parallel medial wall of the lateral ventricle. And of course, occasionally, you may see intrahemispheric cysts, or you may see lipomas if you have ACC, right? And if you have intrahemispheric cysts, they may also communicate with the third ventricle, which is dilated and displaced cephaloid. And of course, if you have intrahemispheric cysts, you have choroid plexus cysts, and you do see orbital anomalies, think of Achilles syndrome. You need to see the cortex also. And the diagnosis of ACC relies predominantly looking at the absence. So as I told you, indirect signs are enough to make a diagnosis for ACC. Of course, the direct sign is the absence of the corpus callosum. That's the normal corpus callosum, and you do not see the corpus callosum. And of course, there are other signs which are predominantly more helpful in the third trimester. And here you see that's the normal mid-sagittal, and you do see the corpus callosum, you see the cingulate gyrus, and you do not see the sulci reaching up to this particular place. And whereas in ACC, you do see all the medial hemispheric sulci and gyri reaching right up to the third ventricle or the roof of the third ventricle, and there is no cingulate gyrus to interrupt it, and that's what is classically producing a sunburst appearance in complete ACC. And of course, you will have an altered course of the pericallosal artery, or you may not see the pericallosal artery, and you may have aberrant vessels seen at the level of the corpus. And the adds. That's the normal frontal horns. You will see if there is absence of the corpus callosum, you will see a typical steer horn appearance of the frontal horns. These are the proboscis bundles. Sometimes you do see these hypoechoic irregular areas which are seen on the medial aspect of the frontal horns. They are divergent and they produce a typical bull's horn sign. And then, of course, coming to the hypoplastic corpus callosum, of course, we do have nomograms. It happens so when you have the length of the corpus callosum is normal, but the entire corpus callosum is thinned out. It may be dysgenetic. You may have things like you may have thinned out anterior part of the corpus callosum, or the splenium may be thinned out. So all these variation can be seen. So you do have nomograms for this. And this happens so when you have a compression due to marked ventriculomegaly, and could be syndromic in this particular fetus, which had polydactyly and micrognathia as seen in acrochilezol syndrome. Now coming to short and thick corpus callosum, just to show an example, in this particular case of a Waka-Waba's syndrome, you do have the outer agyrec echogenic cortex and a Z-shaped kinked brain stem. That's the brain stem. And you have surrounding hyperechoic foci, and that was the thick and the short corpus callosum, which not corresponding to the period of gestation. So you can also come across such kind of anomalies. So once I see ACC, what am I going to do? I'm going to do a detailed neurosonogram. I'm going to look at the lateral ventricle. I'm going to look at the chiasma. I'm going to look at the Csp. I'm going to look at the cortex for polymicrogyria. I'm going to look at the cerebellum. I'm going to look for any extra cranial malformations. I'm going to do a fetal echo to make sure that there is no association of TOF or DRA, because these are the anomalies which are most frequently seen. I'm also going to look at the other parts of the baby. So I need to do a complete survey of, as far as ultrasound is concerned. Well, Dr. Meenakshi will talk about genetics and other things later. And then, of course, coming to the third entity, agenesis of septum pellucidum. So that's the normal cavum septum pellucidum. You have separated frontal horns in normal, whereas then you will have a fusion of the frontal horns, and the fusion occurs because the two laminae, which we see, as I told you, the two laminae of the cavum, septum pellucidum, are absent. So if they are absent, the next structure to be seen is the corpus callosum. I'll talk about it. So I need to rule out holoprosencephaly. I need to see whether holoprosencephaly, I need to look at the fornices for that. I need to look at the shape of the frontal horns. I need to look at the falx, right? I need to look at the corpus callosum. So this is going to help me differentiate holoprosencephaly, the lobar type, right, from this particular entity. Let me tell you, it is very, very challenging at times, right? I need to check for the corpus callosum, the entire length of the corpus callosum. I need to look at the cortex. Look for schizencephaly, polymicrogyrias. Look at the chiasma by ultrasound if you're a good operator, and of course by MR. And then, of course, looking at the optic chiasma, you have an axial section. You're already in the transventricular plane. You just need to go in the same section. You go below, reach at the base of the brain, the suprasellar cistern area. That's a pentagon, and switch on your color box. The moment you switch on a color box, you are going to see the circle of Willis. And the circle of Willis shows you the central band of tissue. That is the optic chiasma. You can also see it by the corneal view, and also use your 3D for looking into the optic chiasma. If you are more energetic, you want to make more effort, you can also go transvaginally and look at this particular area, look at the optic nerve, which is being emitted from the base of the orbit. So that is also possible, because that helps you to show that the optic chiasma is there. Why optic chiasma? Because that's going to differentiate septal agenesis from an entity called as septo-optic dysplasia, right? Which is crucial, because if you have an isolated case of septal agenesis, though there are less case reports, less data, but they tend to have a good prognosis vis-a-vis septo-optic dysplasias. So if I have to say I'm dealing with an isolated case of septal agenesis, I need to make sure my falx cerebri are seen, one. I need to make sure my corpus callosum is seen and my fornix is seen. I have two fornix in case of septal agenesis. I'll be having one fornix in case of holoprosencephaly. I will try to locate my optic chiasma. I will go transvaginally and try to obtain my view for optic nerve. If I have to see, I need to see, and then if I see the cleaved thalami and there is no pronounced ventriculomegaly, my fetal MRI is reassuring as far as the cortex is concerned, then I am quite confident that I'm dealing with an isolated case of septal agenesis, and majority of them will have good outcome. This is just to show you a case of septal agenesis and with multiple anomalies. Now the last, fourth entity, cavum septum pellucidum, is present, but the shape is abnormal. So not only the size, the shape. So that is helped by looking at the Csp ratio. That's a wonderful ratio. Put it on your one of your pages and keep it in your, close to your ultrasound machine, or maybe you can put it on in your iBooks. So you immediately go to the ratio and try to check it out wherever you have a doubt. So normal Csp and a thin Csp. Thin Csp, we need to make sure, one, it is thin. Two, if it is thin, even if there's little fluid in the Csp, and if the length is okay, well, it's only thin. Thin we say when it's less than 2 mm. Right? We need to make sure the other things, as I told you. We need to look at the corpus callosum. The first thing, sagittal imaging. As Dr. Beaton said, if you have something in a doubt, or if you have an abnormal finding on an axial plane, complement it by other planes. It's very, very crucial, because in the sagittal plane, you will see the entire CC, and the CC is normal. It's a reassuring issue. Okay, yes, we just follow up these particular patients. But let me tell you, you need to take it with a pinch of salt. We had a patient with thin Csp in the second trimester, and she landed up with lissencephaly in the third trimester. So things are known, but we need to follow. And this particular entity, this lady had a syndromic baby. They had a thin Csp, but of course, she had bilateral lenticular opacities as well. So thin Csp can be seen because of the obstructive or a pressure effect or a barotraumatic effect of the dilated lateral ventricles. And this can happen when you see cases like Arnold Chiari malformation. And here you are looking at the autopsy picture of the dilated ventricles. You can also see the banana-shaped cerebellum as seen. So this is the case where you have Arnold Chiari malformation, and you do have ventriculum Mckelly, which is causing a mass effect or thinning of the CSP. Then coming to short CSP. As I told you, you can resort to your CSP ratio. Now, this is a lady comes to us as about 20 at about 19 weeks. My CSP, I was not very sure. I'm not looking at a normal CSP. It's a square-shaped CSP, right? The length and the width is almost the same. So, as I told you, I would always rely upon my sagittal. I went in, I did a sagittal image, and I was looking for a very small and short length CC. So I put on my Doppler, and there was the runoff. It is called the snake under the table sign. It wanders off. The pericallosal artery wanders off to the skull table. That means there is a shortening of the CC. Though we followed up, this was a case of partial ACC. Then patient wanted to continue. That was an isolated finding. And then as we see in her at about 30 weeks, we do see the same findings. Again, there was a short CC for the corresponding period of gestation and a similar classical picture of the runoff of the pericallosal artery up to the level, where the CC falls short by this particular length. At that particular area, there's a runoff of the pericallosal artery. So this was a case of partial ACC, and the patient is doing fine till now. So coming to this particular entity, which I would like to show you, once the CSP is collapsed, this is very, very challenging, let me tell you. This was a case where we saw that, the CSP is not there. Mind it, that's not the CSP, right? How we found it? We found it by doing a mid-sagittal plane. So once we did a mid-sagittal plane, we saw that the anterior part of the cavum septum pellucidum is collapsed. So that's the CSP. CSP needs to be seen in the anterior part, right? That was the posterior part of the CSP, and that's the cavum vergi, right? So that's not the CSP. The anterior part is fused. The laminae are fused. It's not absent. You can't say it is ACC, right? Because you see the corpus callosum. Neither can you say that it is agenesis of the septum pellucidi, right? So this is a crucial and a very, very challenging case before we embark upon this particular kind of diagnosis. When we see the CSP is collapsed, it's non-visualized, right? But we need to complement by further imaging, further planes, wide CSP. Look for associated anomalies 1, and it could be a pointer to trisomy 18 and even 22q11 deletion, right? And then this was a case showing you the classical pictures of trisomy 18. And then I've now summarizing group 1, I showed you absent CSP and septum pellucidum, which included holoprosencephaly, ACC, and septal agenesis. I showed you how to look at the optic chiasma in order to differentiate between septal agenesis and septo-optic dysplasia. The second group, I showed you that CSP is present, but the shape is abnormal. Whether it could be thin, it could be short and wide, a square, suspect. Do your mid-sag, as you see in partial ACC. It could be wide, more than 10 mm in width. That could be, of course, chromosomal and could also be related to trisomy 18 and also deletion 22q11. Then I showed you a case of collapsed CSP. Believe me, it's very, very challenging to go through all these cases. So coming to the last part of the talk, midline intrahemispheric variants, we know what CSP is. We know what cavum vergi has been shown. It is the prolongation of the CSP, and we have a cavum villi interpositi cyst. All these are normal variants, and some of them develop cysts, and more or less they have a good outcome if they are isolated. So this is to show you a long CSP many of the times catches our attention. And of course, as I told you, mid-sagittal plane, confirm it. See its communication. If its communication is there that you're dealing with a cavum vergae, you can reassure your child that, okay, yes, this is going to have a normal outcome, right? So favorable outcome. But if you have a cystic long area, please put on your color Dopplers. You may be dealing with a cerebral AV fistula or of the median prosencephalic vein of Marcosvi. And then if you have a case like this where you have a CVI cyst, you need to put on your colored Dopplers. There is no mass effect, just a cyst which is seen beneath the splenium of the corpus callosum and is reaching up to the roof of the third ventricle. Put on your Doppler. See the location of the internal cerebral vein. If it's inferior to it, it's a CVI cyst. And if it is superior to the cyst, it is what is you dealing with a arachnoid cyst. Let me tell you, both of them, if they are isolated, they are not producing any mass effect, they have a good outcome. This is the patient who delivered and her cyst had resolved after 2 months of the neonatal life. And this child is perfectly normal, right? So this is what is imaging does to the outcome of the child. And then, of course, is this a CVI cyst? No. So whenever the message is, whenever you see a cystic structure, it's always a good thing to switch on your color boxes. So this was not a CVI cyst. This was a vein of Galen aneurysm. Follow-up patient had an IUD and at 32 weeks, and you know it happens so because of the high cardiac output. So take-home points are, abnormal CSP could be a hint for many CNS anomalies. Look at the CSP, not only the size, but also the shape. Be aware of all the indirect signs of ACC, which you see on your axial plane of imaging. And of course, complement by any abnormal thing on the axial plane with the sagittal plane, with the corner plane, with the 3D, multiplanar, TUI, etc. Try to visualize the optic chiasma, though challenging but possible, in order to differentiate septal agenesis from SOD. Do not forget looking at the cortex, but they may be giving you better hints than other. Beware of midline intrahemispheric cysts. They may have a good outcome. Thank you so much for a very, very patient hearing.
Thank you very much, Dr. Ladmans, for that very comprehensive presentation. I think we have one question.
Okay.
So basically, Dr. Seema is asking, what's the Doppler setting for pericolosal artery?
Okay. For power Doppler, I think I use power Doppler. And for power Doppler, it's a good idea to have a PRF of about 0.3 to 0.6.
Okay.
Yep.
So I think we'll move on to our next speaker. So our last speaker for the evening is Dr. Meenakshi Lallar. She's a consultant geneticist with Genome Labs and Prime Imaging, Chandigarh. So she's done her DM in medical genetics from SGPGI Lucknow, and she's an ex-consultant at the Department of Genetics and Genomics at the Gangaram Hospital, Delhi. She is a gold medal winner for her MBBS, and also she was awarded the Best Oral Paper Award at the Ivf Pgtm 2013. She has over 30 research publications to her credit. She is a member of multiple societies, including the Society of Indian Academy of Medical Genetics, the Fetal Medicine Society, the Indian Society of Human Genetics, and also the Inborn Errors of Metabolism Society. And her interests are primarily in prenatal reproductive genetics and molecular genetics. So over to you, Dr. Meenakshi.
Thank you. So I am trying to share my screen.
Dr. Ladmans, if you could stop sharing your screen, madam.
Is my screen visible?
Actually, your screen is not completely visible. I think it's cut out a bit, so maybe you'll have to reduce it. I think it's just getting cut out at the corners and at the ends. Maybe you should just zoom out a bit.
I think now it should be visible. right?
Now it's better.
Thank you so much. No, it's not.
One minute.
There is something.
I'll continue in this format. Okay.
Sure.
So now it's visible as a whole, right?
There is still a little bit at the right side. It's not visible. See, like your full name is not seen. A little bit to the left, maybe.
A little bit to the left, right?
Left. Yeah. A little bit more.
I think I think you've
Sure.
done the introductions. I'll continue with this.
Sure.
Okay. A very good evening, everyone. So now we've known the normal, the abnormal. Now, what the basic purpose we are going to do it for is to counsel the patient. We have to tell the prognosis to the patient, right? And so what we want to know is that how do we convey it to the patient? What does actually all these findings means? And the basic most question is, what is going to be the prognosis of this pregnancy? So the patient's concerns after the diagnosis of the fetal anomalies are, so how major is the anomaly detected in my baby? Can it be treated? If yes, fully, can it be treated? Will the baby have a normal birth and treatment? And is there a treatment available for it? And the first and the foremost question they would want to ask is, should we continue this pregnancy? What are the risks if we continue the pregnancy? What are the testing that is available? Should we go for some testing? And what is this testing? Like, what will it detect? How is this testing going to help this baby? How is this testing going to help the next pregnancy? And what will be the reoccurrence? This is a very, very important question. Will it reoccur in the next pregnancy if we do not continue with this pregnancy? And the basic they want to ask is, what went wrong? How did this happen to us? Right? So our aim through genetic counseling is that we want to answer these questions. We want to establish the diagnosis. We want to determine the cause. So genetic testing is a part of genetic counseling, and we go from explaining the diagnosis to the patients. What is the tentative diagnosis? We go in for more genetic testing depending upon what the presentation of the fetus is, and we want to determine the cause. Is it a genetic cause, a teratogenic cause? Because CNS anomalies can be, post certain teratogenic factors also. And what the genetic test is required, and what will be the ultimate thing that we're going to tell the patients. So the genetic counseling journey, sorry, it's getting a bit cut. So the genetic testing, I think the screen is a bit.
Now we are set.
No, yeah. Some things, I think something with okay, I'll have to, show it in this mode only, right? So the genetic counseling journey will start with explaining the condition to the baby or to the patient, advising what further testing is required, and this is to be discussed upon depending what is the gestational age of the patient. We have to decide accordingly what testing will be offered, either CVS or amniocentesis. Obviously, if we're talking about CNS anomalies, it has to be amniocentesis, or whether it is better, the prognosis is actually so bad that would it be better to terminate the pregnancy and then offer some testing. So we can also counsel about the fetal autopsy. And all this is done to reach an exact diagnosis, to determine the prognosis in this pregnancy and for the reoccurrence in the next pregnancy. So genetic counseling is actually, I would like to show here counseling based on actually a case example. So this was a couple who came to me at around 16 weeks. And actually I had animations, but there is some problem with this slide. So the animation doesn't seem to work. So the couple came to us at 16 weeks. They had an abnormal CSP, and it was actually, it was not mentioned what kind of an abnormal CSP is, but just it was abnormal CSP, though we can say that it could be a narrow, wide, or an absent CSP, and rest nothing was significant. The dual risk was low risk. So now this is the history that the couple is going to give it to me. And as a geneticist, my role is going to be, I will not confine myself to the CNS. I'm going to look outside the CNS. My role will be to look at the level 2, the neurosonogram. Is the CSP Was the CSP isolated finding here, right? And I am also going to explain that, see, the scan was done at 16 weeks, and CNS, as is the CNS is an evolving organ. So the brain is an evolving organ. We might get a clearer picture at a later date. But because the prenatal testing, we have certain gestational age capping to follow, but the testing we would like to initiate. So what I told to this couple who presented at 16 weeks with abnormal CSP was, let's get a neurosonogram done and let's get a fetal echo done, because I want to see if there are any other extra any other anomalies associated, because then the prognosis is going to differ. So this is also going to help us to establish the cause and choose the genetic test. So what the patient presented was the level 2, and the rest of this neurosonogram was normal. So it was a case of isolated agenesis of ACC. The CSP showed us isolated ACC, and amniocentesis we planned. But now if you are planning amniocentesis, we have to decide the test. What test do we send in amniocentesis? Do we send a microarray? Do we send a clinical exome? Do we send a clinical exome trio? So I would just like to take you through the levels of genetic testing here. So as we all know, the nuclear material is present inside the nuclear material, the DNA is present. The DNA is compacted into the chromosomes. So the anomalies can be at the level of the chromosomes, right? Like there could be there could be increase in the number of chromosomes, like trisomy 21, or it could be a small one particular gene that can be affected inside the chromosome. So that is a single gene disorder, right? So if it's a chromosomal disorder, a large number of genes are included, but in a single gene disorder, one particular gene is associated. So a very gross way of saying is that if you have multi-systemic effects, if I have agenesis of corpus callosum, I have a cardiac defect, I have facial defect, multi-system involvement, then I would tend to think of a chromosomal anomaly more. But there is also a pattern to it. If I have agenesis of corpus callosum, something in the posterior fossa, something in kidney cyst, and I have polydactyly, this will lead to me thinking it's a ciliopathy like Meckel-Gruber. Then I will think of a single gene. So the testing will change. Here it will be a chromosome. I would like to send for a karyotype or a microarray. It is better to send microarray nowadays, because karyotype is might not pick up the small deletions, duplications. So when you're looking at the chromosomes, we will send the microarrays. And when I'm talking about the single gene, I am going to talk about the NGS based testing, clinical exome, or the clinical exome trio means that you are testing the fetus as well as I'm sampling the parents. So the clinical exome trio, the tests rates increase, but it has a higher yield, because there is something called a variant of uncertain significance. So I just want that the patients should be sensitized that the testing is not a single test. It can be in multiple stages. And yes, to achieve a diagnosis, we might need multiple tests. So the genetic testing, yes, there are two basic types of genetic tests. There are certain targeted tests, and there are certain genomic tests. So the targeted tests are FISH, QFPCR, MLPA, because they are looking at only a few things. And the genomic tests, which are covering everything, are all the chromosomes are the karyotype, the microarray, NGS. So for the CNS anomalies, I would tend to go for the genomic testing. I would go for, if it is a multi-system anomaly, I would go for a microarray. And if it is pointing to a single, it is like isolated, if it is a CNS anomaly, isolated, and no other system is involved, your level 2 is okay, like it was in this case, and there was no cardiac involvement. So I would tend to think of a single gene etiology in that case. So this is just to show you that there are a huge number of conditions that are associated with the agenesis of corpus callosum. We're talking about agenesis of corpus callosum because this patient had agenesis of corpus callosum, right? And so the chromosomal conditions, as you can see, there can be deletions and duplications at various levels. There can be even mosaicism. So any possible conditions you can think of here. And this chromosomal conditions, the chromosomal conditions we can pick up by means of microarrays. The single gene defects are also many, and you can have slight ideas about the different systems that are included. So if there is an abnormal skull shape, You can think of the Apert syndrome, or if there is involvement of the kidneys, you can think of the ciliopathies. If there is involvement of the skeletal systems, there can be certain skeletal dysplasias involved, right? So if it is isolated, it could be X-linked. The L1-CAM is a very important implicated gene here. So a single isolated CNS tends to make you think towards the single gene defects. So the main thing to emphasize here is that the agenesis of corpus callosum with multiple anomalies, the prognosis is usually bad. But when it is isolated, it can vary from mild to severe. So this is what actually needs to be taken in consideration while you are explaining the things to the patients. And there have to be, you know, the appropriate genetic testing. We've already, I would just like to differentiate a bit between the karyotype, microarray, and clinical exome here. Maybe 1 or 2 years back, 4 or 5 years down the line, we were limited to this karyotype. Around maybe in the few years, we were limited to this microarray. But now this clinical exome is the new test that everybody should know. And this is very important when you're thinking about single genes. And you know, the clinical exome, as the technology is improving, it can also pick up the copy number variations. So depending upon we have to counsel the patient all these limitations about the testing. So the turnaround time, which is around 15 days for microarray, around 1 month for clinical exome, all this needs to be told to the patient. The limitations need to be told. So there is something called the pre-test genetic counseling, and there is something which is called post-test genetic counseling. So before doing amniocentesis and a big genetic test in the fetus, it is always recommended that we send the patient for genetic counseling. Why? Because the patient needs to understand what the testing is all about. And you know, no test is going to give you 100% result. There is no single best test. There is no single test that is going to answer all your queries. But patients tend to think so when they are going for such costly tests. But it is very important to tell them that, see, there are certain limitations. And now, as I'm coming back to this case, so this patient, a primary patient, 16 weeks, agenesis of corpus callosum on neurosonogram, and there was no other abnormality. So because it was an isolated agenesis of corpus callosum, we were suspecting a single gene etiology like acrocallosal, Andaman, the alpha dystroglycanopathies, the L1-CAM, or the ciliopathy group here. You know, many of these conditions might not be isolated, but they might be isolated for that gestation. There's some phenotype evolves as the baby grows in size. So here we thought that clinical exome is the best bet, and we wanted clinical exome to be done on the amniotic fluid sample. So how do you explain it in the simple plain language to the patient? So we will tell what is being tested. The patient is going to ask. We'll see that what we are doing is we're taking your amniotic fluid and we are doing a clinical exome that is going to test all single genes related, and around 6,000 to 8,000 genes in number are going to be covered. And we are going to focus on the genes that are associated with the CNS developments. Right? Can very large copy number variations, chromosomal anomaly be detected? Not routinely, but now the clinical exome with certain pipelines is able to detect the copy number variations also. What are the limitations? This is very important to tell to the patients. I always say in this clinical exome testing, we might get certain variants of uncertain significance, which is called WUS. And here additional testing might be required. So it is always better to tell them. So if trio is always a better choice in fetal testing, that trio means you are taking the amniotic fluid of the fetus, plus you are taking the parent sample and doing clinical exome in all of them. Because you know, when you get certain mutation in the fetus, you can know that which parent it has been inherited from. So it is a cost effective. It is a cost effective and a time effective testing technique in fetus, because we have to tell the patient if they need to continue the pregnancy or not. And what happens about that after the test results? After the test, after the amniotic fluid, I tell to the patient, I will be able to tell you what is the disease in the baby, what is the risk of reoccurrence in the next baby, and what will be the natural history of this disease in the baby. So this all I explained to that patient with agenesis of corpus callosum. And finally, the clinical exome was done, and the results are as follows. So QF-PCR is always done because we want to rule out the maternal contamination. So the QF-PCR by default looks at the chromosome 21, 13, 18, X and Y, which were normal. There was no maternal contamination. And the clinical exome report showed that it was actually a trio that they opted for. So this is what a trio looks like. So the index is the fetus, the mother is there, and the father's testing is there. So we got a mutation in the L1 CAM gene. This is the mutation C.2092G2A, and this is the protein form. It was hemizygous in the index. Hemizygous means there is one X chromosome, so I know that that's a male fetus. Heterozygous in the mother, that is, mother has two X chromosomes. So on one X chromosome, this abnormal mutation is there, and this X chromosome went to that fetus, and the father is not a carrier. So it was a pathogenic mutation, and it causes the X-linked hydrocephalus. Now I am able to prognosticate and explain them to the results. This was done with the help of a post-test genetic counseling. The main aims of the post-test genetic counseling are to explain the test results, to explain the prognosis, and to tell what is the risk to the family and the reoccurrence concerns. The test results I explained as that this is a mutation in the L1 CAM gene, which causes agenesis of corpus callosum, ventriculomegaly, and as if the fetus, if you continue the pregnancy, the ventricles will increase in size, and obviously the prognosis is not good. It is not treatable. It is associated with intellectual disability, seizures. So the patient did not continue the pregnancy. And because we know it is an X-linked recessive condition, and we know that mother is the carrier, so though we know that there can be, she can have inherited it from her mothers, and her sisters can be at the risk. And there is a recurrence risk to all the male fetuses she's going to have. And after a while, we can, even help them with the decision of the next pregnancies. We can tell them, see, you can go for a prenatal diagnosis with the help of a CVS in the next pregnancy. Now, Ivf Pgtm is a very, very good step for those patients who want to do not want to go for invasive testing in at all the times in the pregnancy. So Ivf Pgtm, what they do is they take the sperm, the ova, they make embryos, and they test the embryos. And the embryos, with the normal embryos, are taken, and you put the normal embryo you implant the normal embryo to the mother, and the rest of the normal embryos can be frozen for the next pregnancy. So PGTM is a very good option for such patients. And lastly, if the finances do not permit, or if there is infertility or some other causes, you can go in for the donor egg here, because it was an X-linked condition. It can also be a donor sperm if it was inherited from the father, or if it was an autosomal recessive condition. So the carry home message here I would like to stress upon is that genetic testing is very important for fetal diagnosis. The main two important thing is to prognosticate this pregnancy. So in this case, we knew that it is going to have a bad prognosis, so they will discontinue. But had we not got, if I would not have got any mutation and it was an isolated agenesis of corpus callosum, then it is then I cannot be sure. Then what I'm going to tell them is it could be mild, it could be severe. We will see it as the baby grows, as the baby pregnancy progresses, and as the child grows. But still, in most of these cases, parents do not continue the pregnancy. And before embarking on genetic testing, amniocentesis, clinical exome, microarray, genetic counseling helps the patients to understand the fetal disease, what are their testing options, and very, very important, what are the limitations of each genetic test. Because even after a simple dual test, the patients tell us genetic test has been done, everything is normal. even a simple blood dual test, they think in that manner. And if you're doing a clinical exome and such a costly test, they tend to think that everything's going to be covered. So post-test genetic counseling is important, where we tell and make the patients understand the test results, the reoccurrence risk, and how can we prevent it. And genetic test is always chosen according to what fetal disease that I am trying to think. So it is not that I am always going to order a microarray on the fetus, or I'm always going to order a clinical exome of the fetus. If I'm thinking of a Beckwith-Whitman, I am going to maybe go for a methylation assay. If I'm thinking of IUGR and Russell Silver, I can even go for another methylation assay. So the phenotype is going to determine what I am which genetic test I am going to use. And genetic counseling can also, it is very important, coming to a very practical aspect. When there is a severe when there is agenesis of corpus callosum at around 18 weeks, 19 weeks, the patient is not going to want the genetic testing. So in that cases, it is very important to give them the option of either amniocentesis just to store the fetal DNA, or even a better option would be a fetal autopsy, because then we will have the fetal DNA, we will do the testing, even if the parent is not continuing the pregnancy, because definitely we will have the answers for the next pregnancy with us. So thank you. And I would like to end on the note that we need to think genetics, chromosomal and single gene defects. They are way commoner than we think, and they were till now undiagnosed because of the less access to the technology. And as with the wider availability and the cheaper genetic testing, we are finding more and more cases, and we're able to help more and more families. Thank you. I think.
Thank you very much, Dr. Meenakshi, for that talk. I think you've touched upon genetics, and it's an important topic. So I now invite the audience to type in the questions in the Q&A window, and the chat window is also open for your questions. So please utilize them for your questions. In the meantime, I will just carry forward with what Dr. Meenakshi was talking about. So we at MedGenome are partnered with FOGSI to bring about a genetic education series in association with the Fetal and the Genetics and Fetal Medicine Committee of FOGSI, Dr. Mandakini Pradhan. And so we have about 7 talks lined up on the basics of genetics. So we'll be touching upon some of the techniques that Dr. Meenakshi spoke about, including microarrays and next generation sequencing. We'll be touching upon them in more detail, and you can look at the timetable here. So we just finished our first round of talks on basics of genetics. We have clinical genetics coming up next week, and then there's disease-specific genetics, reproductive genetics, and 2 sessions on laboratory genetics where you will be touching upon the various techniques that are there for molecular diagnosis. And the last session will also be on inborn errors of metabolism. So these are the dates and the speakers. Most of them have confirmed their participation. So as and when we are approaching the session, we will be sending out an email to, once you've registered, you will also be getting an email about this session then. So I think a couple of questions in the chat window.
Mr. Joseph, there are 2 people who have raised their hands. Could you just please look into that?
Yes, ma'am.
There is...
I think I asked the audience to use the Q&A window. So I think the hands are down.
Okay.
Yep. So you answered the questions. Yeah, you answered that. So I think there was one on the cost of clinical exome. I'll probably let our local representatives also to follow up on that.
Is it possible for you to allow Dr. Deepika? She had probably raised, and Dr. Indrajit had raised.
Sure. Let me just check if they're still there. Deepika Garg, I can allow her to speak. Dr. Deepika, if you'd like to speak.
Hello, good evening, ma'am.
Good evening.
Ma'am, it was an awesome lecture. I think I'm going to change my brand soon.
Okay.
Thank you.
You and Mitan, they do wonders each time we meet, and every time you just surprise us.
Thank you for such encouraging comments. I think
Thank
that
you, Dr.
makes us
Deepika. Thank you.
do better and better.
Yes, ma'am. Every time there is something more to learn from you. Learning is never ending.
No, it doesn't stop.
Yes, ma'am.
One should be a regular learner, and I think teaching is the best way to learn.
Yes, ma'am. I wanted to ask, like, Dr. Luller said that the cost is around 15 to 20,000. Is it besides amniocentesis, or amniocentesis is included within?
Dr. Meenakshi? Dr. Meenakshi, you unmute yourself, please.
Yeah, so it is actually, besides, it actually also depends on many factors. Like if I go for a trio, it would cost more. If I go for a single exome, it would cost less. But the amniocentesis charges are separate. And if we go for in fetal autopsy, we go for the extended exome. We are not hard pressed on the time, so it is cheaper. But if you go for an expedited one, if you want quick results, because in prenatal you have decisions to be made, so that is going to cost a bit higher. So it depends upon many conditions, how many people you are testing, what is the timeline that you are looking for. But on an average, you can say that it is between 15 to 25,000.
Like in this case, like it was cavum septum pellucidum was absent. So would it be better if the patient goes for termination and then she could go for postmortem, and this could be much cheaper than the amnio and all that?
From the practical aspect, that is what I said, because it was agenesis of corpus callosum, and when there is ACC, we cannot rule out the mild learning disabilities, even if we don't get anything on the genetic analysis. So it's a very valid approach that we tell during the patients, the pre-test counseling sessions, that this is the prognosis, and you can go for a fetal autopsy. That's going to give us a insight into the fetal brain, the extra, all the parts of the body. If there is any associated anomaly, we can even store the DNA for further testing. And that is because the amniocentesis is not included, so that is actually cheaper. That's only the price of the clinical exome then, because most of the people favor the
reinstate the fact that at least storage of DNA must be done. Yes. Because see, otherwise you're not getting anything. Believe me, we all keep on doing ultrasounds, we all get positive patients. If we do not go further and counsel our children or counsel our parents, because the counseling has to be not only from the clinical genetist side, but it also needs to be done from the person who's referring this particular patient. You all gynecologists and even all of us need to counsel for a further evaluation. At least minimum DNA storage must be done, because that's the only way we need to know what happened and how to prevent recurrence, as Dr. Meenakshi has talked about in detail, and also tell the further consequences to happen in the subsequent pregnancy. I think we all need to join in together. If at all the parent does not want to do anything, at least the sample for the autopsy must be sent forth. That part should be willing from the clinician's side as well.
Which sample to send and in which medium?
So I would actually want the whole baby to be sent. What we do is in normal saline, because formalin is going to cross-link the DNA and we will not be able to do genetic testing, always in formalin. And depending upon, if it is a CNS anomaly, I would want the baby to be transported a bit early with ice packs and in normal saline. And we do return the baby after maybe 1 hour. We do the testing at that time, and I give them I explain to them what is being done, what can they expect in the results, and just a plain simple normal saline, the baby needs to be transported.
And is your center doing DNA storage as well?
DNA storage we are not doing. DNA storage actually becomes, like we had a patient with skeletal dysplasia. At presently, they were not financially very viable to do the testing, but because DNA, in a few thousands, you can store the DNA, and then the patient can come back after maybe 6 months, and then they want the testing. Because I see so many patients, and one regret that they have is that we did not know of this testing when it happened the last time. Nobody told us. It was not told. And now, and the next time, the next pregnancy, they are so anxious. And so it really helps if the DNA is stored, if we give them the information. I have seen in my experience, most of people go for it.
So what's the cost of storage?
DNA storage would be somewhere between, I think, 3,000 to 5,000, around 3,000 to 4,000.
And for how long do you store?
We store it for 2 to 3 years. But we do tell the patients that please visit us back after 6 months or prior to you plan the pregnancy. Absolutely.
We'll ask our local representatives to probably get in touch with Dr. Deepika for further queries on her. So if there are no further questions, I think we can conclude our session. So thank you very much, Dr. Amitam, Dr. Ladbans, Dr. Meenakshi, for taking time out from your schedule for this webinar, and also Prime Imaging and Diagnostics Chandigarh. And so we'll be having our next session sometime next month. We'll get back to the exact dates and the schedule in a couple of weeks, and we hope to see you there. So if you have any further queries about genetic testing, we are available at the toll-free number given below, or at the email ID diagnostics@medgenome.com, or visit our website medgenome.com. Find out more about all the tests, the trioexome, clinical exome, and also our reproductive genetic portfolio, which has an IPT, carrier screening, implantation genetic testing, POC, RPL, and the regular cytogenetic test. So once again, thank you very much to the audience for your patient listening and also signing in and attending this session. I hope it was insightful. And as mentioned before, we have more series coming up for basics of genetics. We hope to see you for that too. And so thank you again to the speakers, and have a good night.
Thank you, and good night to you all and all the delegates. Thanks so much for sparing your precious time.
Ma'am, hats off to you, ma'am, hats off. You have taken 1.5 hours for us.
That's okay. We all learn. That's the
Thank you.
Right.
Thank you.
Bye. Good night.
Thank you, everyone.